Awesome. We gotta love technology and the different things it brings. Once again, good afternoon, everyone. My name is Keyandra Whiteside. I am Mrs. Bloomington 2022. I'll be competing for the title of Miss Indiana for America on May 7th. It is my pleasure to welcome you all on behalf of the Shades of Becoming a Mom, a 501c3, a Black and maternal health and infant law support organization based in Indiana. This is the inaugural Race, Equity, and Minority Health discussion in observance of Black Maternal Health Week. Black Maternal Health Week's activities are sponsored by Indy's Massage Company, the District Tap, Comedy Sports, Tinker Coffee, Tyler Mason Salon and Spa, Indianapolis Symphony Orchestra, and the Hancock Regional Hospital. Thank you all for your sponsorship. As a friendly reminder, this session is being recorded so that it may be reviewed by others after this live session has ended. If you have any questions, please type them in the chat, and we will work to address as many questions as possible. But until then, please remain on mute. At this time, I would like to introduce the founder and president of Shades of Becoming a Mom, Tieree Reid, Mrs. Central Indiana 2021. If Tieree can come off camera so I can give her a STEAM introduction. Awesome. Tieree Reid is the principal consultant of Tieree Reid Consulting, LLC. And she's a certified coach, trainer, and speaker with the John Maxwell team. As you can see, she's very busy. Previously, Tieree served as the Vincennes University's Assistant Dean in Instruction, where she oversaw associate degree pathways in 3 school districts, including VU's flagship early college program. And under her leadership, Area 31 became the only American Society of Health System pharmacist, an accredited high school program in the nation to offer an associate's degree. That's phenomenal, Tieree. Before serving at VU, Tieree was a central office administrator at Goodwill Education Initiates, where she helped develop, launch, and manage the Excel Center for Adult Learners, Indiana's first tuition-free adult high school to offer adults an opportunity to earn an Indiana Core 40 high school diploma. Tieree Reid has more than 2 decades of experience in K-16 administration and nonprofit management. She is currently pursuing a Doctorate of Education and Curriculum and Instruction in Higher Education at Oakland City University. Tieree holds a Master's of Science in Student Affairs and Higher Education from Indiana State University, a Bachelor's of Arts in Speech Communication from the University of Minnesota Morris, and several professional education certificates. She is a proud alumnus of the Harvard Graduate School of Education's Women in Education Leadership Program for senior level administrators in education. Please welcome Tieree Reid. Tieree, you are on mute.
Let me unmute myself. Sorry about that. So thank you, Keyandra, for that introduction and for your previous experience with the Indiana Maternal and Child Health Fatality and Prevention Committee, as well as planning the Indiana State Breastfeeding and Labor of Love conferences, that if you have not heard about those 2 organizations, you should please look into those. Your continued commitment to Black maternal health and partnership with Shades of Becoming a Mom is so greatly appreciated, and we are looking forward to more great things, as well as you hitting the stage for Mrs. Indiana America. Thank you to today's panelists for graciously agreeing to share their knowledge and passion for today's topic. Let me start by introducing our first panelist for today. Our first panelist is Maryann Chimhanda, Dr. Maryann Chimhanda. She is an assistant professor of clinical obstetrics and gynecology at Indiana University School of Medicine. Dr. Chimhanda is a graduate of the Master of Science in Medical Science program and Doctor of Medicine program, both at IU School of Medicine. She completed her residency training in obstetrics and gynecology at Loyola University Medical Center in Maywood, Illinois. Dr. Chimhanda spent almost a decade in Kokomo, Indiana, providing comprehensive OBGYN services before joining IUSM in June 2020. Dr. Chimhanda was selected as the Curricular Thread Director responsible for addressing racism and promoting care for the Black community. And this position is supported by the Indiana University School of Medicine's Primary Care Reaffirmation for Indiana Medical Education Prime Grant. She is also a member of the Indiana Maternal Mortality Review Committee under the Indiana Department of Health. Welcome, Dr. Chimhanda. Our next panelist that we will introduce will be Dr. Adriena Beatty. Dr. Beatty is a devoted wife, mother, and daughter. Her devotion to her family is what makes her daily to be a better person. She is an Army veteran that has practiced obstetrics and gynecology for over 15 years. She graduated from Tuskegee University with a degree in chemical engineering and chemistry. She is a certified physician executive and has a master's degree in business administration. She has a passion for education and philanthropy, which is why she has started Let's Talk with Dr. B. Let's Talk with Dr. B is an educational series for young girls, teenagers, and women regarding their bodies and women's health. Let's Talk with Dr. B is a platform that makes medicine easy to understand. Welcome, Dr. Beatty. Our next panelist is Brenda Graves-Croom. Brenda Graves-Croom is a licensed social worker specializing in depression, anxiety, and trauma, and serving a diverse clientele, including people of color and immigrants at Catalyst Counseling in Indianapolis. Brenda is the former Health Equity Director for the Division of Mental Health and Addiction with the Indiana Family and Social Services Administration. She is the past President, VP, and Secretary of the Mental Health of America Hendricks County Board of Directors. Brenda is a former commissioner for the Indiana Commission on Hispanic Latino Affairs and the Intricacy State Council on Black and Minority Health. Brenda earned a Bachelor's of Arts degree with a double major in sociology and Spanish from Indiana University. She earned a Master of Social Work with a concentration in mental health and addiction from Indiana University School of Social Work. Welcome, Brenda Graves-Croom. Thank you. At this time, we're going to begin our discussion with our speakers. Each panelist was given a set of questions to address as they have 15 minutes of an opening statement. And so they'll spend about 15 minutes as stated addressing a specific topic. We'll go from one panelist to the next and then the third panelist. After the third panelist, we would then open up for questions and answers. As stated earlier, please type in all of your questions in the chat, and please send those questions to either Keyandra or myself, Tieree Reid, and we will try to include those questions as time permits. So the first question that I'm going to be addressing is to Dr. Chimhanda. The question is, first I'll start with, structural racism and unconscious bias, dates back to slavery, that has been stated. And so women, at a time where women's bodies were being used to create theories and practices, and that continued through time without consent or even with consent of African-American women. And so we see some type of systems of unconscious bias as well as racism that has been put within the healthcare system. So my question to you is to help us understand the importance of anti-racist curriculum in addressing institutionalized racism in obstetrics and gynecology, or just specifically within the medical field, and a few strategies to identify and eliminate racist policies and programs in the healthcare system. So if you can take a little bit of time to address that for us, that'd be greatly appreciated.
Thank you, Ms. Reid. And greetings to everyone who's present here today. In response to your question, I have a short couple of slides to go over that kind of gives an overview of what we're doing as an institution at IU School of Medicine to increase our knowledge base as providers and learners, and faculty who train learners on how to minimize this bias. So I'll share my slides. Can you see my slides okay?
We cannot.
Okay, just a moment. Okay, so today can you see the slides now?
Yes.
Okay, so I'll focus today on communication skills and why those are important in medical training, and give you an example of how we have implemented that in our institution. First, I would like to acknowledge Dr. Bradley Allen and Dr. Paul Wallach and the other co-PIs of the PRIME team. So PRIME essentially it's a grant from HRSA, and this particular grant is allowing us as an institution to improve access to primary care by training more primary care physicians, but we're also including in this grant the opportunity that I'm enrolled in or serving as the curriculum thread director. And our goal is to enhance health equity as well as reduce disparities. So in my current role, I serve as the health impact of systemic racism and caring for Black communities. I'm charged with helping, along with my colleagues, Dr. Catherine Chartier and Allison Thomas, in developing the curriculum and our competency that will address these issues. So first, I will define implicit bias, which a lot of you already know, but we would like to highlight what that means. And then we will review how the statistics from maternal mortality play a role and how these things are intertwined. The idea is that if we can reduce implicit bias, then we can improve maternal health. So as medical institutions, our governing body called the AAMC has also already outlined a framework for eliminating racism. Part of this involves self-reflection, institutional directives, just as I've stated, rather called the PRIME grant, and then involving medical communities as well as speaking up, which is one of the things that your program is doing. We're speaking up about the barriers that our patients experience. So implicit bias really highlights unconscious or hidden thoughts that we may have towards people, towards others. Unfortunately, these biases tend to be negative. And a lot of times we may not even recognize that we may have bias. So that's why education is important in this arena, so that way we can identify ways in which we're looking down on others or ways in which we're mistreating others. Microaggressions refer to everyday incidents. These things could be verbal, they could be nonverbal, they could be intentional or unintentional, but unfortunately, the result leads to negative messages. And unfortunately as well, certain groups are targeted. So this leaves particular groups marginalized and then affects their care. So regarding the maternal health and the reason why we're here for this week, we all know that about 700 women will die per year from pregnancy or pregnancy-related complications, and Black women are 2 to 3 times more likely to die. Even with the best care, or even with, more social or like a higher socioeconomic standing, there are actually no things that separate us as women who suffer from these complications during childbirth. So it becomes a very big problem, because regardless of where your background is, each of us are affected, and it's very important that we as a community, regardless of our status, that we all come together to fight this national problem. Maternal mortality can occur during pregnancy. It can occur in the postpartum period. And maternal mortality review committees track these deaths up to a year after delivery. Here in Indiana, we do have a maternal mortality review committee. I would refer you to the Indiana State Department website to look at the reports from the last 2 years. A review from 14 other states showed that the main causes of deaths were cardiovascular complications, including things like preeclampsia, hemorrhage, infections. Unfortunately, again, 2 out of 3 of these deaths could have been prevented. So how do we consider anti-racism? How do we consider the concepts of implicit bias and microaggression? The reason that we put all these things together is because it affects our care. Regardless of the intent, like I mentioned earlier, there are consequences of experiencing a microaggression as a patient. It disrupts our relationship with our patients. It also affects our ability to deliver high quality care. And high quality care is needed to improve the outcome of each of our patients. And then for us as providers, it also creates, burnout and creates poor wellness, which in turn can affect how you take care of your patient. So how do these things connect? Maternal health, microaggressions. When we look at these concepts, we can tell from many different articles. I just picked out just one commentary which described that patients' trust in their physicians were decreased significantly. Also, for example, patients reported that their postpartum pain was not well controlled. So this brings up the question of how do we change our process? How do we change how we think of our clinical decision-making? So first, we have to engage our patients. We have to hear what our patients are reporting. Secondly, we have to change some of the algorithms that we use that involve or include race and thereby affect appropriate decision-making for our patients. So for example, the trial of labor after cesarean section cesarean delivery calculator used to include race as part of the algorithm, but this is no longer included. And hopefully this should allow us to increase the number of patients who are able to proceed with a vaginal birth after a cesarean section without having the alternative route. This particular commentary suggested a couple of domains by which bias could be reduced. One was education and self-awareness. The other was communication and then cognitive reframing. As an institution, these concepts are things that we are committed to, and I will discuss that in the next couple of slides. So the HRSA project, which I was fortunate to be a part of, is sponsored with Dr. Bradley Allen and Dr. Paul Wallach, all deans from our institution. This particular grant is going to affect all 9 campuses. Our goal is that we can improve the skills of our graduates. Our goal also is that we increase interest in primary care centers. And this is of particular interest because we are aware that there are maternity deserts here within our state. And if we can improve interest in primary care careers and thereby increase interest in things like obstetrics and gynecology, then we're able to send out well-trained providers into these communities to make a difference. But in addition, we want to make sure that our graduates have all the tools they need to provide equitable care. So our anti-racism education that we are working on centers around, number 1, relationship-centered communication, cultural competency and humility, and then advocacy. The crux of everything that we do starts with how we speak with our patients and how they receive what we say and how we understand how they speak. So it is important to us to engage in skills building that would allow us understand patients, but not only that, but help us identify our own biases so that we can properly provide care. This past spring, our third-year medical students engaged in a virtual session that was organized by myself and Dr. Catherine Chartier and Dr. Allison Thomas. We started off with a didactic session and then provided each of the students with communication skills that they could then demonstrate and further use in their clinical settings. There was also review of real life clinical scenarios that occurred, and these videotaped scenarios were used to help the students practice the skills that we had taught them. There was opportunity for each of the students to talk as a group, small group, and then as a larger group. Some of the skills that we taught, number one was creating a therapeutic alliance and focusing on the patient's health. This particular skill sets allows patients and doctors to talk in a way where if there's any misunderstanding or poor perception about someone's background, that a conversation can be started or addressed. The second skill, naming a behavior that's not appropriate and then exploring why that particular behavior was carried out, is something else that we taught. And then we also encouraged each of our learners to learn how to share their perspective, but not just theirs, but gain the perspective of the patient that they were speaking with. At the end of this session, our students gave great feedback stating that these skills that we thought were very useful in helping them in the clinical setting. So in conclusion, enhancing communication amongst patients and providers will help improve patient outcomes. It's very important that we remain self-aware and focus on professional development, because this helps us to gain empathy for our patients, and it helps us to engage our patients in the best way possible to ensure that they get the best care. And to tie this in with maternal health, anti-racism education definitely will help reduce health disparities within our Black communities and thereby improve maternal health. Thank you.
We are now going to go to Dr. Beatty, who will answer the following question. What are some of those complications that's happening to Black women? As Dr. Chimhanda stated, that even with the best standard of care, women are still experiencing poor maternal outcomes, regardless of education. And so what are some of those complications that are happening within that community? What's happening in America in our medical community that might be contributing to these issues? And what should women look for to advocate for themselves? Very, very hard question, but I know that you can answer that.
Can you hear me? Do you have my slides? Okay. And thank you, Dr. Chimhanda. That was excellent. And I wish that all medical schools had that program that you're doing at University of, at your institution. Oh, pulling up on my end. Okay. All righty. All righty. Did you allow me to share the screen then? I'll just share my screen then since I have them. Sorry. Share.
You have screen sharing privileges.
Okay, thank you. All right. Can you see my screen now?
Yes, you're going in and out.
Give me a chance. No or yes. I love technology. Can you see it by any chance or no?
It's going in and out.
Okay, well, gotta love technology. Okay, well, all righty. Well, we're just gonna, I'm not going to worry about it, and I'm just going to talk about it since I don't, or if you find it, Tara, and can do it, then I'll just talk and then we can go from there if you get it to where you can screen share. So hi, so like Tara said, I am Dr. Adriena Beatty. I've been an OB-GYN for 15 years. And I would like to start out first with just a statistic, about maternal mortality. So that we have to take into account is that Black women are 2.9% more our non-Hispanic white counterparts. So that equates to about 55.3 deaths per 100 live births in the United States. When we look at our non-Hispanic white counterparts, ourselves Hispanic, we are the largest. You say something, Tara? Oh. Our race is the largest as far as maternal complications that can occur. And it's unfortunately has increased over the last number of years. We have not done a great job in decreasing that mortality rate between African Americans. Some of the most common complications that we do see are high blood pressure, gestational diabetes, preeclampsia, preterm labor, to name a few, but those account for the majority of our complications, just like Dr. Chimhanda had previously mentioned. I would like to discuss a case study with you that kind of goes in line with the mortality and just how we as institutions should start to look at, and also what happens in our institutions sometimes, which also goes to what Dr. Chimhanda had previously mentioned as far as educating our students and our medical professionals how to treat and how to handle different situations as women come into the hospital. So I had a 29-year-old patient who was a well-educated patient. She was on her second pregnancy, and she presented to the hospital with abdominal pain. It was subsequently found that her baby's heart rate had decreased. So she was then taken to the preoperative suite and then told that she had to have an emergency C-section. During this time, she presented to the hospital alone. During her C-section, or trying to get her ready for C-section, she was trying to contact her family. But in this time, it was her phone was kind of taken away from her, things of that nature, because they were trying to get her ready for the surgery. The surgery was then performed. She was put under general anesthesia, and the surgery was performed, and the baby was delivered at 29 weeks. When you talk and successfully went to the NICU, when you talk to the patient afterwards, her perception of that event, even though the hospital did a wonderful job of getting her baby out, baby went to the NICU and was taken care of, her perception of the event was very different than what people may assume or may think. You would want to assume that one, she would be grateful, her baby was saved, things of that nature, and went to the NICU, but her perception was very different. One, she felt like nobody heard her because she was alone and she was unable to contact her family to let her know what was happening. Two, she felt almost assaulted in her getting ready for the C-section because nobody told her what was going to happen, what was going on during that event. So just to look at that as of things from a patient perspective, a lot of times we do surgeries and we have C-sections and we perform surgeries to get babies out, but we forget that there are two patients in the room. Yes, there's a patient that's a baby, but yes, there's a patient that's a mother. And so we have to remember of one, how we do informed consent. We tend to use a lot of medical terminology, which is relevant, but you have to remember to educate that person in a way that they understand the informed consent. And two, to remember the patient's perspective and that being informed along the way of what's going to happen during her case and during her surgery. So she ended the case and she is very thankful, like I said, baby was delivered and is doing very well, but unhappy with the care she received during the time of her C-section. And so as an OB-GYN, I have many women who come to me and always ask me, what can they do to be an advocate for their healthcare? One, I would like to say first, is to ask questions. But let's start for just the fundamentals. First, write down your questions of what you want to know during your care. Write them down. And I always tell patients, write them down, put them in your cell phone, write them in the note section, something like that, so that you remember, because patients always remember their cell phones at appointments, but will forget that piece of paper they left on the counter. Number two, it's okay to ask a provider or to tell a provider, I do not understand what you just said. Can you explain it to me in a way that I can understand? That's an okay question to ask, and you shouldn't be ashamed if you don't understand. Three is to advocate for yourself, meaning that if you don't understand something, to ask questions. If you want a different way of care, or if you have questions about the proposed management, it's okay to ask questions and to be an advocate for yourself. And another important thing is to actually find a provider that is a fit for you. It is okay to find a provider that you are comfortable with and that will understand what you're saying, that is listen to you in the office. It is okay to find somebody. I have a lot of patients who have come to me and they have said that they have stayed with the same provider just because their mother went to them, their family member went to them, they went to them as a child, and they feel that they're obligated to stay with that person. And that is not the case. Find a provider that you feel comfortable with. I cannot stress that enough. And number three, the last statement on number three, sorry, is to find an advocate. There are a lot of things advocate for you for in the delivery room. You can find a doula, somebody that can be there for you in the delivery room, that can advocate for your care also. And also is to be informed. It's okay to look up research and to be informed when you come into your appointments, but just also take into account that everything you read on the internet is not actual medical facts and knowledge. So to have that conversation with your provider so that you can get the best care possible. And sorry that my slides didn't work, because I had all of this on slides. Tara, how much more do I have? Time do I have?
You have a few more minutes.
Okay. All righty. So those are the biggest thing. When we look at mortality from a perspective in the United States, like I said, we're trying to do strides to decrease mortality, but the biggest thing is to be an advocate for ourselves and for your care. And that is it. So thank you. If you have any questions, please let me know.
Mute myself. Thank you for that. Our next question is going to be addressed to Brenda. Brenda, if you can start, thank you. So the question to you, mental health has been the major topic, if you will, within the pandemic. What individuals, regardless of what their health situation may be, experiencing an uprise in mental health, and then people considering mental health that may not have, because I know in conversation, you can look at research, but also in conversations with friends that are African American, that some things that they experience is just everyday life. It's just normal stress. It's not a mental health thing or anything like that. And so this is also yet another area where women do die after giving birth, in postpartum, sometime afterwards. Also, women do commit suicide while pregnant or after they have given birth. And so what I want you to talk about is, what are some of the known racial disparities that exist in maternal mental health as experienced by Black birthing population, and what strategies would you recommend for dismantling the barriers to mental health care for Black women and Black birthing populations? And actually, let's keep that specific just within mental health, because that's just huge altogether. And so whether or not if you are birthing or not, mental health in itself is just important.
Mm-hmm. Absolutely. Thank you for recognizing that and making a place for mental health during this discussion, because it is so important. We're seeing now with the pandemic just how important it is. And the most recent statistic that I heard was that we're up to about 50% of the general population that's experiencing some sort of mental health disorder. Usually it's depression or anxiety. And so as I look at this subject, there are many common themes that go across healthcare disparities, regardless of whether it's mental health or some other kind of healthcare disparity. And so some of the studies that I was looking at, and I apologize, I don't have a presentation for you, but I do have some great facts and information that I want to share. So I will start with Scientific American and an article, a wonderful research article that was put out on racial disparities, screening for postpartum mood disorders. And so one of the first facts that I was blown away by is that new mothers of color experience postpartum mood disorders at twice the rate, which is 38% of white mothers in the US, and up to half do not receive any support or treatment. And this is a tragic statistic that can easily be changed. And we'll talk about some of the solutions. And so I don't want to focus too much on the problem. I want to be able to kind of weave in solutions throughout as we talk about what the problem is. And so women of color are less likely to be screened for depression compared with white women during the postpartum period. And in this particular study, they looked at Adriena Health in Minnesota. And Adriena Health is the largest provider of obstetric services in the state. So there are 7,548 women that are going to these clinics. And so the statistic that they provide is that compared with white women, the following groups are less likely to be screened. Asian women at 19% less likely, compared to African American women, 36% less likely, and then Native American, Hawaiian, Alaska Native, and multiracial at 56%. And with the multiracial, I would imagine that we would also have a mixture of mothers of color, of Black mothers as well in that statistic. And so why is this happening? And so, you know, I was really happy to see that Dr. Maryann mentioned implicit bias and structural racism. And so they are part of what is contributing to the problem. And there's social determinants of health. Social determinants of health, meaning our socioeconomic status, our education. Studies show that the higher your socioeconomic status, the higher your education, then your health will be better oftentimes as well. And so they look at these studies, they look at large groups of people that have particular identities through their socioeconomic status, their race, ethnicity, their gender, etc. And so then they also hold for these factors as well as they look at the disparities. And so we've seen ways that racial ethnic groups have been impacted in history through many different oppressive activities, oppressive things that happened, policies that were implemented, and as a result, we see great disparities across the board with all those different factors. And so when Dr. Maryann talked about relationship-centered interactions, that makes me think about person-centered care. And person-centered care is about having a relationship with the person that we're serving. And it's about asking for feedback. And it's about having respect for what that person thinks and what's happening with their own body. And I believe that we are all an expert of our own body, and we should be a part of that shared decision-making that happens. And so she also talked about cultural humility. And so cultural humility is really important because it is one of the frameworks, one of the cultural frameworks, along with cultural competency, that, and they go really hand in hand. And cultural competency, I think it kind of gets a bad name because of the term competency. And you think, well, how could you ever be truly culturally competent, right? It's a journey. And so cultural competency over the years has developed, started out really maybe about 20 years ago, and then cultural competence, cultural humility came along maybe about 10 years later, and I believe really saw some of those gaps within cultural competency. And so using both cultural competency to address our knowledge, our attitudes, our awareness, and our skills in dealing with people from different cultures than our own. And then with cultural humility, more of a focus on addressing power imbalances and addressing accountability of institutions, and really doing a strong self-reflection and critique, especially as providers, because we know that we bring bias. We don't leave our bias at home. We bring it with us to the workplace. And so making sure that we're aware of how our bias affects the way that we interact with folks is super important. And so as we're looking at structural racism, I want to go into that a little bit here, but going back to the study that I was talking about earlier, a 2018 national survey showed that the most important factor is if a clinic prioritizes the screening. And so they could use, the solution there was text-based screenings or virtual peer groups or one-on-one peer mentors. And so you think about what is a one-on-one peer mentor? It's this relationship that we have with that those folks that we're serving, whether you call them patients or clients or consumers, et cetera. And that's another thing that we need to talk about is the terminology that we use. And so in my opinion, prioritizing screening means that, one, we're going to look at policy. We're going to put into policy that this is a screening that needs to happen with all women, especially women of color. Two, we need to put it into practice. We need to know about what assessment tools are out there so that we can use those tools effectively and get training on those tools. And so even an evaluation scale like the Edinburgh postnatal scale, the EPDS, where they look at during the pregnancy and up to a year after the pregnancy, symptoms that are common for women when it comes to depression and anxiety. And so this is a way that we can prioritize making sure that these screenings happen. And it showed that the non-Hispanic Black women have higher rates of postpartum suicidal ideation than other mothers. And so unfortunately, as Tieree had mentioned, that there are mothers who are dying of suicide. And this is a really important subject that we need more data on, and we need to focus on, and we need to advocate for. And so as I go back and I talk about some more in relation to addressing power imbalances and having accountability of institutions, there was a really wonderful article that I found, a study through Health Affairs, an organization called Health Affairs. And the article was Pathways to Equitable and Anti-Racist Maternal Mental Health Care, Insights from Black Women Stakeholders. And I love the fact that now there's so much more of an emphasis on anti-racism than there ever has been before. One good thing that I believe has come out of the civil unrest that we've experienced in this country is more of awareness of racism within our systems and how to address it with anti-racism. So when we talk about anti-racism, and I think it's important to discuss what that is that we're recognizing, and that's the first thing, is to recognize that there is racism within our systems, to identify what it looks like, and then to oppose and dismantle systems of oppression for racial and ethnic groups. And so as they did this qualitative study, they talked to Black women stakeholders on what these women believe to be the problems and the solutions. And so the article proposes that structural racism causes inequities in the diagnosis and access to treatment for perinatal and maternal mental health. And so the solutions that they propose are, one, education and training for providers, things on implicit bias, microaggressions, et cetera, things that have already been mentioned. Investing in the workforce, that was mentioned as well, making sure that there are folks that look like us, people that look like the patient that can serve the population, investing in Black women-led Black women-led community-based organizations. And so with the work that I used to do at the Division of Mental Health and Addiction, that was one of the things that we were working on, is being able to promote more Black-led community-based organizations that we can contract out to do outreach through folks like community health workers, and addressing traditional healing practices with doulas and midwives. And we've talked about that already, but you think about the connection that they have with the patient. Integrated care being really important. Integrated care meaning that we are integrating medical care and mental health in the same facility, in the same area. And so instead of referring someone out to a psychologist, psychiatrist, licensed clinical social worker, et cetera, licensed mental health counselor. And there's so many different professionals within the field that vary in different ways, that we have those folks within our own facility or within our network. And so it's more of a warm handoff than referring someone outside. And finally, really putting a focus on the shared decision-making and that person-centered care and patient autonomy, which is important to address disparities like this. And that's it. One last thing that I wanted to mention was the terminology, that sometimes it can be kind of depersonalizing, whether we talk one of the things I try to stay away from is saying my caseload, or my clients, et cetera. And so really trying to focus more on the person and talk about the folks that I serve. And lastly, remembering that folks are not simple, they are complex. We have intersectional identities, and those identities that can contribute to the privileges or oppressions that we experience in society. And the last of two things, that people don't always cooperate, and people don't always agree. And so we have to work with folks, use strategies like motivational interviewing, et cetera, to be able to help that person in their care. Thank you so much.
Thank you so much. That was a great perspective from a mental health standpoint. We're now going to move into our question and answer portion. Starting off with Dr. Beatty, a question for you that was posed in the chat was, in your opinion, how can OBs and doulas create better, effective relationships for the highest good of the patient?
One, I think that it just starts with communication between both parties. I have worked with a lot of doulas. One of my good friends is a doula. So I have a really good relationship, but it's also just communication. And actually, it would be good if the doula would come to your appointment prior to you going into the hospital, so that they can meet your provider and we can all get on the same page, right? We can all talk about the expectations of everybody in the room at time of delivery, and so that we can get a better understanding. Because sometimes what happens is that you come into delivery and neither party has met, and there may be different expectations or different expectations between the two. So it'd be nice if you could, if possible, if your doula would come to an appointment before maybe one of your appointments at the end of your pregnancy, but also just communication, and to keep an open line of communication between the three parties, the patient, the doula, and the provider.
Awesome. Thank you for that perspective. I do think communication is the foundation of a healthy relationship, a healthy delivery. So thank you for that perspective. Another question that was posed for Dr. Chimhanda: would there be a focus on trauma-informed care within the training program that was talked about, that you mentioned? Since everyday life stressors come and go, past trauma plays a huge impact on the health of the pregnant woman and unborn child. So how would that focus-informed care play a part in the training program for the IU School of Medicine students?
I think that that's something that we already incorporate in other aspects of the curriculum. However, that's something that we will include, but my team and I hadn't included that at the time because we do talk about that in other aspects of the curriculum.
Awesome, thank you. And next question that was posed is for Dr. Graves-Croom. What are some of the strategies for increasing awareness of personal bias? Like you said, we all have bias, we carry it with us. What are some strategies for us to notice it within ourselves?
So that is a great question. So one of the things that I start to think about when you ask that question is, where is our awareness at? And so it is a journey. And as you know, even at my ripe old age of almost 48, I'm still learning a lot about myself. And I'm still learning why I do certain things, why I think certain ways. And so if I have a particular reaction, a lot of times it's happening on a subconscious level. And I'm so busy, I'm moving, I'm trying to get things done, I'm not really paying attention. And so it means that I need to slow down. I need to stop and think about, how someone is reacting to me. If there's a particular response that was elicited in the way that I spoke to them, the way that I interacted with them, and try to think about, okay, well, what's going on here? Did I say something in a biased fashion? Did I make a look? Did I do something to put out that I don't really approve of what it is that you're doing or you're saying, right? And so there's some aspect of judgment there. And maybe it's something that I've learned along the way as I've grown up, or I've been around different groups of people. And so really being able to have that self-critique and evaluation on a daily basis. And my mother asked for some feedback on some sort of leadership thing that she was wanting to be a part of. And she had to elicit the feedback of her children. And so that was the most difficult thing that I could ever do, was to critique my mother. But my mother said, what a scary thing that was. At my age, I thought I was done with self-critique. We're never done. It is a journey.
I love that last statement of we're never done. It's a journey. Life is a marathon, not a sprint. So thank you for that perspective. Another question in the chat is it better to handwrite information to patients when caring for them postpartum so they have something to refer back to? I worry about adding the stuff they get and then it getting lost. So thoughts on writing information down? Is it going to be misplaced? What are your perspectives? Yes, Dr. Beatty.
I could tell. I do understand what you're saying, because when somebody gets pregnant, we give them a whole bag of stuff. And also when you have a baby, you get a whole bag of or folder of stuff. I find that it's better. I actually do a lot of writing down in my appointments. And I think that you can still give the stuff, but just remember that when you're at the appointment, individual appointments of the different weeks, or even when they come in postpartum, I think if you give it to them one-on-one at that appointment, and you actually then write it down for them at that appointment, and you hand it to somebody at their 20-week appointment or 28-week appointment, they actually keep it and retain it more than just giving them, I agree, this big bag of stuff, even though, I think I'm guilty of it. I have 2 kids, and I'm not gonna lie, I didn't read the bag of stuff either till I was like at home. I was like, oh, this wasn't, And it was 4 weeks after I had my kids. So I am guilty as a physician. You just get overwhelmed, you have a new baby, and it's the last thing you're gonna do is read what's in the packet. But I think if you start addressing these things at their appointments, at the 28-week appointment, give them a little bit of information at the 30-week appointment, 32-week appointment, and then they can keep that and then read it individually, I think it makes a better impact than the bag or folder of stuff we give people at the beginning of their pregnancy. I know we do it at the beginning, we get a whole bunch of stuff at 28 weeks and then at postpartum, but we found giving them at little chunks is a lot better throughout each appointment.
Awesome.
I would like to add that utilizing the electronic medical record system is also valuable. So some of the instructions can be placed in their electronic chart. And as long as that electronic system has a patient-facing version, then they can look it up at any time. So that's another way. And then in addition to doing, like Dr. Beatty said, in addition to doing it at different stages, I think when we round on our patients postpartum, going over those discharge instructions are important pieces of it, such as those postpartum signs that we should be looking for, like headaches or shortness of breath or chest pain or feeling sad, going over that every time you see them at their postpartum hospital visit. So in addition to hearing it from multiple sources, then there's that element of repetition. So it becomes something that they're familiar with. They've heard it from the staff and the providers in clinic. They've heard it in the inpatient setting. And I also like to recommend that we teach family members some of these discharge instructions, because they are going to also be the ones that will be looking, and you essentially give them permission. Please call if you notice that your family member doesn't want to take a shower. They don't want to hold the baby. They've been up all night. Those are very important things that family members, can also help us with.
Yeah, I totally agree. And also just giving the patient the right to say, it's okay. It's okay if you get overwhelmed. It's okay if you feel this way. Like, it's okay. Even as a physician, and even have children, I felt overwhelmed at times. And validating to a female that it's an okay thing. You're not crazy or alone or by yourself, or somebody's going to look at you funny or think that you're this way or not a good mom. Like, that has nothing to do with it. And so just validating to them that everybody goes through it, and it is okay to have those things, because we've all felt that way, thought that way. And it's okay. And I think that's the biggest thing to get a point to people. And it's okay to reach out. Nobody's going to think anything different of you because you reach out. Right. We actually want you to reach out so that we can help you.
Right. There's a tremendous amount of stigma, isn't there, associated with it? And just like you were saying, that it's normal, it's common, it's what happens. And then there can be folks who, women who don't want to accept that they could be possibly experiencing these symptoms. And so it's, working with them in a way that they can make those changes that they need to make through the strategies that you use with them. And then in terms of the information, so I'm not located within a large system, but one of the things that I like to do is to have a really personal connection when it's possible, and send articles, email and text. And I know that in this day and age, we're becoming more text-based, and we have telehealth as well. And so, people might think of that as being impersonal. There's so many different ways that you can still be personal with telehealth and text-based sorts of support with literature and information.
Yeah.
Thank you for all that feedback. I think it's great how you all touched on the mental health aspect, but also giving them information in tidbits where it's more digestible than a big plate. And then Dr. Graves-Croom, I love how you said that mental health aspect, that stigma, because sometimes we have to give ourselves permission to feel, give ourselves permission to speak on those emotions, those frustrations, and give ourselves that chance to explore that versus letting it all settle in. Another question that was posed in the chat: for those who are considering getting pregnant or those who are pregnant in their early trimester, how would you encourage them to engage in education and training for childbirth and postpartum care?
I guess I'll take it first.
Yes, go ahead.
So if you're thinking about getting pregnant or you are pregnant, one, you can start where you are. You can ask your provider, or the things given by the institution that you're maybe affiliated with. Your hospital have some really good things. There are also things in some communities that can also reach out. So I would start there. And ask your provider, because honestly, they probably know the things in your area that actually are the resources that are available to you in your area, because that does vary depending on where you live and things of that nature. So I would start there. I think it's a good idea to know those resources, because when you are in your postpartum period and you go home and you find yourself needing those resources, you at least want to know what is available before you may or may not need the resources. So I think it's a good conversation to have just with your provider and just ask them, hey, what's available? What you mean, or where should I be? You know, are there classes available at the hospital? Some hospitals provide childbirth classes. There's other organizations within the community that provide childbirth classes. I know there are some available online also, that even if you can't, they're not available in your area, there's some available online also to do.
I would like to add 3 resources. For those who are considering pregnancy, it's important that you make an appointment with your obstetrician for a preconception counseling visit. Depending on the medical conditions that you may have experienced in a previous pregnancy, this would be an opportunity to optimize those conditions. So for example, if you have hypertension, we can try to make sure you're on appropriate medication that is compatible with pregnancy. If you have diabetes, for example, we can help bring down your hemoglobin A1C and get your diabetes under control. And then for the high-risk patients, they can also make an appointment with a maternal fetal medicine specialist to address any complex birth experiences that they may have had or experienced. And then for the pregnancy standpoint, there are 2 resources that we have out there. There's one called Postpartum Support International. The web link is called postpartum.net. It's a great resource to help patients who are experiencing depression or anxiety. They have many online support groups that you can do from the comfort of your home, and they address different groups of birthing moms or birthing people. So there's the class for NICU moms or support group for NICU moms. So there are different variations of it. So check that website out. And then the last resource is called Count the Kicks. It's an app that you can download that would help you with tracking your baby's movement. We usually have you track movement from about 28 weeks, but the benefit of doing this is that you can do it about the same time every day. And if something changes in baby's movement, then you know you need to go to the hospital. The reason why this is of importance is because once again, there's that disparity in terms of having unexplained stillbirths. So I will post links to those apps in the chat.
And another resource that I used to give patients also was like psychologytoday.com. And it's for people who wanted, who are taking out counselors, and you can put in your zip code, your insurance information, and it would actually bring up counselors that take your insurance and are within your own zip code.
Perfect. Thank you for that. And thank you for putting it in the chat in advance. Another question on the lines of like resources and seeking out different providers. When should a woman get a second opinion based off the information she's received?
A second opinion from because she's pregnant, or just in general? Is what they're
just
asking?
in general, or because she's pregnant. You can take it from either standpoint.
Okay. I mean, I venture to say, as a patient, I mean, well, I'm saying you can get a second opinion whenever you want to, I guess. But I would hope that you would have found a provider that you trust. Because I think that is the biggest key. I think when I think about patients who came to me for a second opinion, majority of the time it was because whoever their provider was, they didn't exactly trust from the beginning. And I think that is normally the majority of the time the case, not always the case. So hopefully maybe you'll start from getting a provider that you trust from the beginning, so that when you do have those conversations, it can be a conversation that you can both engage in. And so therefore you won't necessarily need or feel like you have to go outside of your provider to get another opinion.
Great, thank you. Another question we had: what kind of support is provided for families after they suffer the loss of their wife or mother or their child during that childbirth time period?
So I can jump in here and address some of that. So I love the fact that Dr. Beatty mentioned Psychology Today. I believe that's how Tieree found me for this speaking engagement. And it's a wonderful resource. And there are other resources out there as well. But any sort of grief and loss therapy would be super, super important. Support groups as well. There are lots of times many online support groups that are available, and specifically for women of color. And trying to find someone that's a good fit for you can be really important. So for example, on Psychology Today, you can look for what are called allied therapists. And so, for example, I am allied with women of color and the LGBTQ community, et cetera. And so that's really important to be able to, as part of that trust factor, to know that someone, even if they don't necessarily, hopefully they can identify as you do as well, with their race, ethnicity, et cetera, or their LGBTQ plus status. But if they don't necessarily identify as you, then you're looking for what's called an allied therapist, someone that's going to be culturally responsive for that particular cultural group.
That's great, thank you. And also providing those resources as well. To wrap up, a final question I have for you all is, the statement a lot is said of, I don't see color, or I treat all my patients the same. What are your thoughts on healthcare providers treating their patients the same, not considering their race, identity, socioeconomic status, what have you?
I'll answer that one. I think it affects how you deliver care. If I do not understand your person, meaning what you bring to the table, then I'm not going to be able to appropriately address any of the barriers that you're experiencing. So for example, if you had to take a bus for your appointment and you were 30 minutes late and I refused to see you, then I didn't do my due diligence because I did not find out why you were late for your visit and what barriers were involved in that process. So it's important that we actually get to know our patients, and that can be done over several visits. I know that there are time constraints in how we practice medicine, but as you establish care with a patient over time, you can get to know who they are. You can get to know their family background. You can get to know what things occur with them on a day-to-day basis. Other examples of that would be if your patient's diabetes during pregnancy is not controlled, what's her work schedule like? So you do have to understand that we all are unique and different. And for that reason, how you deliver care has to be personalized.
And I would also like to say, as a provider, it's okay to actually ask your patient. I mean, I've had patients of different races, different backgrounds, and I would just say, I am not familiar. Can you educate me? And a patient will appreciate the fact that you actually care enough for them to explain things to you. And we have a conversation about it. Like, I'm sorry, like I don't know maybe this religious, enough about this religious preference and things like that. So can you educate me so that I can deliver the best care I can to you, because I may not know everything either. So I think as a provider, knowing that it's okay, and patients really appreciate the fact that you're willing to learn about their culture and their experiences, if you may not know because you just don't know. And I know I've done that many a time and say, can you educate me? Because I may not know. And I'm not going to pretend that I know every race and every culture and anything that goes about when dealing with that. So it's okay to ask. That's what I would tell my counterparts, actually.
In addition to that, Dr. Beatty, asking is very important, because otherwise we assume, for example, I am of Nigerian heritage or ancestry, and you don't want to assume that every single Nigerian patient that you meet has the same lived experiences, because we all don't.
Exactly. And I agree. My mother's from Panama. And so you look at me like, oh, you're, American and, African-American. And I'm like, well, true, but my mother's from Panama. So there's a lot of different cultural things that people assume because of when they see you and what you look like. And unfortunately, it happens even amongst our African-American community.
Yeah, that implicit bias. The brain categorizes and classifies what it sees, and it has learned, and then you respond in that way, right? And so we respond to skin color, we respond to gender, we respond to dress, we respond to the way someone presents themselves. And then in doing that, there's all this information that our brain has gathered subconsciously and makes a particular judgment call, and then can respond in that way. And so we have to learn that people are complex, and that we're not one identity, and it's not a vacuum. We're not just our race and ethnicity, for example, but we're also, you know, our gender and our socioeconomic status and our education, and those things mix in a way that are very complex. And so we can't just make assumptions about, okay, well, this person is this or that, so this is how educated they are, or this is whether they'll be compliant with treatment, or this is whether they'll be able to withstand more pain, because we've heard these stereotypes and things, and subconsciously we respond in that way.
Thank you, all of you, for that perspective. Before I close, I'll pass it off back to Tieree Reid to give some thank yous.
I need to take myself off of mute. You know, I just want to say thank you so much for partnering with Shades of Becoming a Mom to put on this session and to have this very important conversation. And I really am looking forward to what will come next for everyone that is a panelist and Shades of Becoming a Mom, as well as all of the individuals that decided to join us. So all of the participants, I want to thank you as well for being a part of this. Before you leave, because the chat information will be saved, if you can put in, if you feel comfortable, your name and where you're from, if you want to stay connected in a more tangible way, we would love to use you if you are interested in being used to volunteer, because there's just so much work that needs to be done. One of the things that came to mind, and I'm going to probably say this, you'll hear me say this throughout the year. Last year, when I was campaigning pregnancy and infant loss, I was championing that through the Mrs. Indiana America organization. And I kept running into organizations that said, we don't have African-American women to serve. We don't have African-American women to serve. And there are a lot of programs that are out there. They are free and open to women that are pregnant, maybe that are dealing with addiction while pregnant. And so there's lots of services out there. And many of those services are going to be either uploaded on Amos Anchors website for pregnancy and infant loss, as well as the sbmom.org website. We really want to connect African-American women to all of these services that are out there so that we can drive down some of these outcomes, because there's lots of great services that are out there. So I did want to state that we need to find you and love on you, if you will. And so I encourage everyone to stay connected on our Facebook page. Do register. We have other events that are coming up this week. And the one event that I want to highlight, because we talked about some heavy stuff, race, equity, and maternal health, but here's the next heavy thing: honor her. There are women that are out there that are doing extraordinary work, like the women who are on today. Honor her. A doula, a midwife, a nurse, a doctor. Maybe there's a mom that has lost a baby. Honor her. Maybe there's a husband. I know it's honor her. Maybe there's a husband that lost a wife. Honor him. So if you can go into the Eventbrite page, there is a ticket that says honor her, and then they have questions. So if it's a male, let's make this gender neutral. Honor him as well. Let's celebrate the individual that is doing this great work. It's a lot of, we heard all of these statistics, but there's also as much extraordinary work, if not more, that's happening in this space. And so I did want to end on that note with everyone. Again, I thank you so much for being here, and I look forward to spending the rest of the week with you. You all have a great evening.
Thank you.